Start off this video by saying I'm not a doctor, I'm not a physician, I'm not a dietitian, I'm not a nutritionist, I'm not a chiropractor, I'm not an RN, I'm not an LPN, I'm not, a practicing licensed practical nurse, I'm not a chiropractor, I'm not an ND, I'm not an MD, I'm not a DO, I'm nothing like that. So let's start with using plant-based foods to reverse type 2 diabetes, because what this video series is about is, okay, so Metformin, to recap, Metformin is popular amongst people that are trying to achieve life extension, and it acts on certain aspects of the physiology that are responsible for type 2 diabetes and reversing type 2 diabetes. There's other ways to reverse type 2 diabetes. So let's talk about using plant-based foods to reverse type 2 diabetes like I did in my last video, which is more of a study. So here's some ideas of how you can focus on incorporating more plants into your diet. Okay, as with any lifestyle change, success comes by taking small, manageable steps. When switching to a plant-based diet, the task may seem daunting and overwhelming, but remember, you don't have to make any drastic changes, especially not all at once. Always start by making changes that you feel comfortable with. Try meatless Mondays. Remember that eating more plant protein tends to make you live longer, and eating more animal protein tends to make you live shorter. So look at this. This is plant protein versus animal protein. Okay, incorporate more plant-based foods with fruits and vegetables. Okay, so if you have a preference for specific fruits and vegetables, start there and expand on that. Pick a new to you vegetable, meaning a vegetable that's new to you. Keep repeating this process until you have increased your repertoire of fruits and veggies and new recipes. Plan to add a serving of fruit to meals throughout the day, either as a side, a snack, or mixed in. Choosing plant protein to reverse type 2 diabetes. Okay, oat milk is not plant protein. I don't know why they're putting that here. There's no real protein in oat milk, nor in almond milk. A single soy-based yogurt might be helpful, but, whatever. I think that there are better places to start, like lentils or beans or things of that nature. So we're going to move on. So some people might remember that I pointed out in the previous video about how a low carbohydrate diet based in whole plant foods or in plant foods did not raise the risk of type 2 diabetes despite having the added monounsaturated and polyunsaturated fats. So is there a diet that's moderate to low in carbohydrate that's plant-based? Yes, there is. It's called the Atkins diet, or plant-based low carbohydrate diet. On body weight and so this is what it does to body weight and blood lipids. Okay, remember, hyperlipidemia is high fat in the blood. Okay, so what are the results of the 47 subjects? 94% completed the study. Weight loss was similar for both diets, meaning both the control, what was the control? The control was a lacto-ovo-vegetarian. Okay. So, however, reductions in LDL concentration and total cholesterol and lipoprotein, blah, 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 okay, reductions in systolic and diastolic blood pressure were also seen. Conclusion, a low-carbohydrate plant-based diet has lipid-lowering advantages over a high-carbohydrate, low-fat weight loss diet in improving heart disease risk factors not seen with conventional low-fat diets with animal products. So one more time, a low-carbohydrate plant-based diet, Atkins, has lipid-lowering advantages over a high-carbohydrate, low-fat weight loss diet in improving heart disease risk factors not seen with conventional low-fat diets that include animal products. Okay? So keep that in mind. Now, many people know that I'm a big fan of Joel Wallach. and I'm a big fan of Bruce Ames, and I'm a big fan of the triage theory of aging and disease. So what role do vitamins and minerals play in type 2 diabetes? Well, let's see here. Vitamin A. Okay. So the term vitamin A comprises various chemical components with a structure and functional similarity. The most active form is retinol, present in animal tissues, esterified with long-chain fatty acids. Carotenes that are present in vegetable tissues are enzymatically hydrolyzed into retinol and converted to retinol in the enterocyte. Some xanthines are also converted into retinol. Vitamin A participates in multiple metabolic processes such as genetic expression, cellular differentiation, and growth, having a very important role in the immune system, fetal development, sight, taste, hearing, appetite, and spermatogenesis, meaning the creation of sperm. Retinoids have a very important function as antioxidants, thus helping to maintain the organism's homeostasis when subjected to various forms of stress. It has also been postulated that retinoids may be involved in hepatic lipid metabolism, adipogenesis, as well as pancreatic B cell function, so that's the beta cells in the pancreas, while retinol binding protein, a protein that transports retinoids, has an important effect on insulin sensitivity, acting as an adipokine. A mouse model that lacks the gene for retinoid dehydro that participates in the generation of retinoic acid to be utilized in lipid metabolism shows better lipid profiles than mice with adequate So even though further research is needed to identify the precise mechanisms by which retinoids and their pathways affect carbohydrate and lipid metabolism in health and disease, it is clear that adequate vitamin A intake concentrations reserves should be maintained in the normal healthy individual, and in particular in those subjects with chronic diseases that involve carbohydrates and lipids. Very old age type 2 diabetic patients have lower plasma concentrations of vitamin A and carotenoids. On the other hand, serum retinol concentrations have been found normal in adult diabetic subjects with lower carotene and higher retinol than controls. A nested case control study showed that high levels of plasma beta-carotene are associated with lower risk of diabetes. So this is, again, the plant form of vitamin A. Beta-carotene is associated with a lower risk of diabetes. Retinol binding protein, particularly retinol binding protein 4, together with transports retinol from the liver to the peripheral tissues by binding to specific cell receptors and has been linked to lipid metabolism and insulin sensitivity. Retinol status modifies retinol binding protein 4 expression, and their ratio is used as a marker for retinol sufficiency. Increased plasma concentrations have been observed in diabetic subjects, also associated to plasma TTR levels. Increased concentrations have been shown to lead to low glucose uptake by skeletal muscles. Complications of diabetes include retinopathy, cardiovascular disease, neuropathy, and non-alcoholic fatty liver, among others. Some studies have linked retinol binding protein 4 to these diseases. However, the results are still controversial. Okay. Additional to retinol blood concentrations or urinary excretion, an important measurement of retinol metabolism, its relation to retinol binding protein concentrations, and although this ratio is high in diabetic patients, the cause of this is not yet clear. So let's talk about the B vitamins: thiamine, riboflavin, niacin, pantothenic acid, pyridoxine, biotin, cobalamin, and folic acid are usually grouped as the B vitamins, and although most of them have been linked to type 2 diabetes mellitus, there is not much information on riboflavin or pantothenic acid. Thiamine acts as a coenzyme in the active transference of aldehyde groups and glycation, as well as neurotransmission and neuronal conductivity, and may have effects on the development of various diabetic complications, such as neuropathy. Obviously, we know, orthomolecular people know that thiamine helps with neuropathy. Okay, so it found that increased DNA glycation, meaning increased cross-linking in the white blood cells, the leukocytes, from diabetic patients with neuropathy, which were decreased after a 5-month thiamine and peroxidine supplement. Low levels of thiamine and increased renal clearance have been found in both type 1 and type 2 diabetic patients. In a cross-sectional comparative study of normal controls, microalbuminuric and macroalbuminuric DM patients, thiamine was lower in diabetics with a progressive disease with albuminuria, meaning they're passing protein, more so in macroalbuminuria. A negative correlation between thiamine and lipid profile was observed in microalbuminuria. Various thiamine supplementation studies have been conducted with positive results. For instance, the administration of thiamine during 1 month has been shown to decrease glucose and leptin in diabetic patients when compared to controls. Pyridoxine B6. Vitamin B6 comprises a group of 3 related compounds and their corresponding phosphorylated forms. The active form of this vitamin is pyridoxal 5-phosphate, or PLP. It is an aminotransferase, also acting as a coenzyme. Wow, they spelled coenzyme wrong. For glucose phosphorylase, for the utilization of glucagon in the liver and muscle, thus participating actively in glucose metabolism. Newly diagnosed diabetic patients have lower PLP concentrations when compared to non-diabetic subjects. Okay, so long-term placebo-controlled trial of combined folic acid, pyridoxine, and B12 supplementation found no differences in the risk of developing type 2 diabetes, although homocysteine levels were lower in the supplemented group. So keep that in mind. The homocysteine levels were lower. Even though B6 status is not clearly associated with the development of type 2 diabetes mellitus, there is evidence that its deficiency may be affecting negatively the progression of some of its complications. So keep that in mind. It might not directly be associated with type 2 diabetes, but it might be responsible for the increased progression of some of its complications, such as neuropathy, retinopathy, kidney failure. Okay, so in humans, the combination of pyridoxine with thiamine, but not alone, has been shown to decrease DNA glycation. So keep that in mind. Pyridoxine with thiamine has been shown to stop cross-linking, to reduce cross-linking in the leukocytes, in the white blood cells of diabetic patients. A 6-month supplementation trial showed a decrease in retinal edema and an increase in light sensitivity in diabetic patients with non-proliferative retinopathy. Niacin, vitamin B3, nicotinic acid is a component of NAD and NADH, which are essential for ATP production and energy efficiency at the cellular level. Not much research has been done on the relation to diabetes. However, niacin supplementation has been found to increase HDL cholesterol, meaning high-density lipoprotein, which is the good cholesterol, so-called good cholesterol. It decreases triglycerides and decreases low-density lipoprotein, or bad cholesterol. Cholesterol, it is used as a lipid-lowering drug, either alone or in association with other lipid-lowering drugs. However, its effect on reducing cardiovascular disease is not clear. These lipid-modifying effects may have a role in diabetes-induced atherosclerosis, meaning the hardening of the arteries, cell adhesion molecules, which mediate process that result in atherogenesis, meaning the hardening of the arteries. The expression of CAMs is increased in, so that would be in cell adhesion molecules, is increased in diabetes. Niacin supplementation has been found to reduce monocyte adhesion to endothelial cells, meaning it stops these monocytes from adhering to the soft muscle of the blood vessels. Okay, so niacin supplement, when niacin is supplemented as a coronary drug project, where niacin was supplemented in men with previous myocardial infarction and normoglycemia or impaired fasting glucose, showed a slightly increased risk of type 2 diabetes mellitus. Suggests that nicotinamide excess from an increased in niacin, thiamine, and riboflavin population intake through food fortification may be associated with oxidative stress and insulin resistance, thus exerting a negative effect. So they're saying that it could be somewhat negative. So let's talk about biotin. Biotin is a cofactor for carboxylases. Okay, biosynthesis and elongation of fatty acids. So it can help you turn short-chain fatty acids into long-chain fatty acids. Although mammals do not produce biotin, its deficiency is rare due to its presence in a wide variety of animal and plant foods. Not much research has been done in relation to type 2 diabetes mellitus. A study of biotin and chromium picolinate supplementation of type 2 diabetic rats resulted in anti-diabetic effects, apparently preventing insulin resistance in skeletal muscle by an increase in the expression of the glucose transporter protein. Cobalamin, or B12. Vitamin B12 is a coenzyme in the single carbon metabolic pathways. Okay, so this is its deficiency due to DNA damage or faculty repair or faulty repair is involved in cancer. So keep that in mind. B12 deficiency is responsible for DNA damage and faulty repair in the DNA, which results in cancer, vascular diseases, and some birth defects, while consequently hyperhomocystemia also, so that means that you have way too much homocysteine. This is also related to folic acid deficiency. So if you have a deficiency of B12 or a deficiency of folic acid, you're going to have high homocysteine. In fact, you can actually test for low. I mean, it's really crazy. You can test for low folate and B12 by testing the homocysteine levels, or the adverse is true also. The Woman's Antioxidant and Folic Acid Cardiovascular Study, where women with or without cardiovascular disease risk factors were supplemented with folic acid, pyridoxine, and B12 or placebo during approximately 7 years, showed no differences in the incidence and development of type 2 diabetes. Okay, while suggested that the subjects at risk of developing diabetes should be screened specifically for. Okay, so. Can say polymorphine developing B12 and folic acid supplementation. So it is presumed that the vitamin B12, vitamin B6, and folic acid supplementation might help reduce the risk in these individuals. However, concluded in their systematic review of the cohort studies that there is scarce evidence that cobalamin deficiency can be considered a risk factor for mortality from cardiovascular diseases or diabetes. On the other hand, type 2 diabetes mellitus is an oxidative stress disease. So keep this in mind. Type 2 diabetes is an oxidative stress disease. Vitamin B12 and folic acid deficiencies in diabetic subjects have been found to be associated to increased oxidative stress in relation to a resulting hyperhomocystemia, meaning high homocysteine. As a result of this association, it is conceivable that vitamin B12 deficiency should be considered a risk factor for diabetic complications. Again, it might not prevent diabetes itself, but it might help slow or stop the diabetic complications. Retinal edema and increased light sensitivity in diabetic retinopathy has been found to improve with the supplementation of pyridoxine, folate, and B12 combined. Okay, type 2 diabetic Nigerian individuals showed higher levels of total homocysteine and low plasma concentrations of vitamin B12 than normal controls. Atherosclerosis is another frequent complication related to diabetes. Okay, there's a significant association between increased levels of homocysteine and arterial stiffness. Vitamin B12 deficiency is not common in the general population as it's present in most animal food sources. So again, if you're a vegan, you should probably be taking vitamin B12, being frequently present in strictly vegetarian individuals. However, the prolonged use of metformin, now this is, again, remember I stated, one of the side effects of metformin is what? One of the prolonged use of metformin, the drug of choice, is in uncomplicated diabetes causes cobalamin malabsorption, meaning that if you are taking metformin, it affects your ability to absorb B12, increasing your risk of deficiency. Okay, so for instance, a cross-sectional, now this is another reason I do not take metformin for longevity. Okay, B12 is a very important vitamin. Okay, so a cross-sectional study found low plasma levels of vitamin B12 in type 2 diabetic patients who were using metformin, while a retrospective review of medical records also showed this association. Short-term metformin therapy has been found to decrease cobalamin in elderly patients. Short-term metformin therapy has been found to decrease cobalamin, vitamin B12, in elderly patients. On the other hand, vitamin B12 deficiency has also been reported in diabetic patients not taking metformin. So also, diabetics in general probably aren't absorbing B12 too well. Diabetic subjects who were using metformin showed worse cognitive performance. So they showed worse cognitive performance if they were on metformin than those without metformin or non-diabetic individuals. The authors suggest the use of vitamin B12 supplementation to improve cognitive performance. So it is suggested by these people that did this study that vitamin B12 be supplemented, cobalamin be supplemented in order to improve cognitive measures, okay, cognitive performance, okay. So measured intracellular and extracellular markers of B12 metabolism. They found normal extracellular but decreased intracellular B12 in type 2 diabetic patients or diabetic subjects, whereas metformin use reversed the effect. Supplementation studies have shown a rapid recovery from this deficiency. So when you're deficient, you take B12 supplements, you see a rapid reversal of the deficiency to normal levels, okay? The association between metformin therapy and B12 deficiency in diabetic subjects, which led to the recommendation of supplementation with the amount available in general multivitamins, however, this is not necessarily monitored or practiced regularly. A meta-analysis of 17 studies showed that supplementation with lipoic acid and methylcobalamin improved nerve conductivity velocity. So alpha lipoic acid or ribolipoic acid, or not ribo, there's alpha lipoic acid and R lipoic acid, but lipoic acid and methylcobalamin, meaning the pre-methylated form of B12, improved nerve conductivity and velocity and diabetic neuropathy. After reviewing the information, these people conclude that diabetic patients who are using metformin are at a higher risk of developing B12 deficiency and its consequence, hyperhomocysteemia, okay, folate, folic acid, or B9. The term folate includes 150 components of the family of pteroyl glutamate, which participate in cell replication by enzymatic activity, okay, in purine-based synthesis for DNA, and are an important cofactor for the transamination in the conversion of amino acids, particularly homocysteine to methionine. Folates are present in animal tissue, leafy vegetables, so this is your food sources. I supplement with folate. So folates are present in animal tissues, leafy vegetables, legumes, nuts, and nuts. Their deficiency has been associated with megaloblastic anemia, meaning what happens is you get less red blood cells and big red blood cells, neural tube defects, which is a birth defect, cardiovascular disease, cancer, and senile dementia. So not getting enough folate is associated with anemia, neural tube defects, cardiovascular disease, cancer, and senile dementia. If people remember my video on Down syndrome and a couple of my videos on autism, it's also associated with that too. The implication of folic acid in the pathogenesis of type 2 diabetes is associated to B12 deficiency and its consequent hyperhomocysteemia. And although its deficiency is not widespread, supplementation trials have been carried out in diabetic patients. Okay. Low intakes of folate and B12 in type 2 diabetic patients were associated with hyperhomocysteemia. DNA damage is measured by the presence of micronuclei can be reverted by folic acid supplementation, thus reducing the effect of oxidative stress in diabetic patients. So supplementation with folic acid reduces oxidative stress. Type 2 diabetes is an oxidative stress disease, okay? So, positive effects on signs and symptoms of diabetic retinopathy have also been found with supplementation of pyridoxine, folate, and B12. They keep repeating that. Vitamin C or ascorbic acid. Ascorbic acid participates as a cofactor in multiple reactions, particularly acting as a potent antioxidant in collagen neuropeptide and carnitine synthesis, increasing iron absorption, inhibiting histamine release, and stimulating the immune system. The main cause of increased requirements of vitamin C in type 2 diabetes mellitus is the high level of oxidative stress caused by hyperglycemia. So the high blood sugars are causing increased oxidative stress and increased cross-linking, which makes you require more vitamin C. Vitamin C and vitamin E concentrations, as well as antioxidants, have been found reduced in diabetic patients with respect to healthy controls. Plasma vitamin C concentrations have been inversely correlated to glycosated hemoglobin, meaning the red blood cells are being cross-linked, and fasting and postprandial blood glucose and oxidative stress, but not on lipid profiles. Diabetes has also been associated to periodontal disease, meaning gum disease, and vitamin C supplementation together with dental maneuvers has been shown to improve chronic periodontitis, meaning gum disease. Vitamin C has also been shown to reduce anxiety levels, but not stress and depression scores in diabetes. So it does reduce anxiety, but it does not decrease the stress and depression levels. Okay. A 3-month supplementation of vitamin C and E decreased hypertension, blood glucose, while increasing superoxide dismutase and glutathione levels. These are two of the most powerful antioxidants in your body. So that's SOD, superoxide dismutase, and glutathione. Vitamin D, or cholecalciferol, is an unsaponifiable heterolipid of the steroid group. It has two basic forms, D2, found in plants as a product from ultraviolet B radiation, and D3, which originates, it's produced when ultraviolet B radiation hits your skin and your cholesterol gets converted to D3. Vitamin D3 can be synthesized in the human epidermis or ingested through fish oil, egg yolk, fortified foods, or supplements. Vitamin D is converted into 25-hydroxy vitamin D in the liver, which is the main circulating metabolite. When it is measured, it reflects intake and endogenous production. The active form, which is vitamin D receptors, are present in most tissues, including the endothelium, vascular smooth muscle, and myocardium. The first two are able to convert. Okay, vitamin D has a role in the regulation of many genes, so keep that in mind. It regulates gene expression, such as those involved in insulin production and the development of vascular smooth muscle. So it helps with the development of your smooth muscles that keep your blood flowing proper, which is the reason it is thought to be an important contributing factor to cardiovascular diseases. Epidemiological data suggests that 9 out of 10 cases of type 2 diabetes mellitus can be attributed to modifiable lifestyles. However, changes in these are hard to accomplish and maintain in the long term. No, they're not. Vitamin D receptors are present in pancreatic beta cells and in immune system cells. Additionally, its role in the regulation of calcium absorption is well known. Vitamin D participates in the activity of beta cell endopeptidase dependent on calcium and can act through two main pathways, directly inducing beta cells to secrete insulin through an increase in intracellular calcium concentration through calcium channels, or by mediating beta cell calcium dependent activation. The role of vitamin D in the function of pancreatic cells can be mediated by the union of okay, vitamin D can work through the activation of 25 okay, the expression of so the evidence suggests that vitamin D can improve insulin sensitivity and promote pancreatic beta cell survival by modulating the effects of cytokines and nuclear transcription factors. Okay, on the other hand, vitamin D deficiency has been associated with obesity. So when you don't have enough vitamin D, you tend to be fat. Although the mechanism is already unclear, it's supposed that due to vitamin D accumulation in the adipose tissues, and this is true, vitamin D goes into the fat. So what happens is you need more if you have a higher body fat concentration. Okay, let's go to another vitamin here. Vitamin D deficiency is a risk factor for cardiovascular disease. Elderly patients with type 2 diabetes are prone to develop vitamin D deficiency. Vitamin E, tocopherols and tocotrienols form the vitamin E complex. However, only alpha-tocopherol is present in human plasma, and as all the other forms are not exchangeable, they are not considered for human health. Vitamin E has a very important antioxidant role in the organism. Although it can be substituted by other antioxidants, it also participates in additional processes such as activity of microsomal enzymes and protein kinase C, induction of apoptosis in tumor cells. So vitamin E helps to encourage cancer to kill itself. That's what apoptosis is. Okay, inhibition of platelet aggregation, meaning it helps stop platelets from clumping up, modulating essentially it's somewhat of a blood thinner, a natural blood thinner, modulating the immune system, gene expression, cell membrane stability, and erythrocyte formation, meaning it helps make red blood cells. Among other vitamins, vitamin E has been found decreased in patients with type 2 diabetes. So among other vitamins, like the ones just mentioned, vitamin E is also decreased in type 2 diabetes. High concentrations of alpha-tocopherol have been associated with decreased risk of diabetes. So higher concentrations of alpha-tocopherol have been associated with a decreased risk of type 2 diabetes. The effect of vitamin E on risk of diabetes and its complications is most probably due to its role as an antioxidant. Okay. Some supplementation studies with vitamin E as well as other vitamins have shown positive effects on hypertension, blood glucose, and antioxidant status, high-density lipoprotein function, meaning good cholesterol function. Okay. Other studies have shown no effect. Okay, but there are a number of studies that show positive effects. Vitamin K, okay, phytoquinine and whatever form of vitamin K complex are present in many animal and vegetable foods. 7 coagulation proteins as well as glutamates, and protein in the matrix are present. Various studies have associated vitamin K with insulin sensitivity, glucose metabolism, and thus with diabetes. For instance, the pre-dimed Study in Spain evaluated dietary vitamin K intake and markers related to diabetes. Baseline values showed no associations. However, after 1 year of follow-up, it showed no associations until 1 year of follow-up. Those subjects with the highest intakes had lower ghrelin, glucose-dependent insulinotropic peptide, glucagon-like peptide. So in this same study, a lower risk of diabetes mellitus was observed with increased vitamin K intakes. A retrospective Dutch database analysis of vitamin K intake and incidence of type 2 diabetes mellitus after approximately 10 years follow-up found that the plant form of it and the animal form of it intakes were inversely associated with risk of developing diabetes. Multivitamins. Most of the studies we have reviewed until this point refer to individual vitamins. However, there has also been research on use of multivitamin supplements and their effect on different outcomes in type 2 diabetics. We believe that this type of research should be analyzed separately due to the possible interactions between nutrients. The 2010 Dietary Guidelines Advisory Committee did not recommend the use of multivitamins for general healthy population, but they indicated that some specific diseases might benefit from supplementation. This is the case with type 2 diabetes. And several studies have been undertaken to evaluate the effect of multivitamin and mineral supplementation. For instance, the use of daily vitamin B group and antioxidant vitamins in diabetic patients resulted in an increase in folic acid and alpha-tocopherol concentrations with a reduction of homocysteine. Supplemented patients also reported having non-significant decrease in number of infections when compared to the placebo-controlled group. Multivitamin/mineral preparation. Only multivitamin/multimineral or placebo during 4 months showed a significant reduction in blood glucose. So only the vitamin-mineral supplement showed an improvement. Long-term use of dietary supplements, including multivitamin/multimineral, B complex, vitamin C, carotenoids, vitamin E, calcium with vitamin D, omega-3 fatty acids, flavonoids, lecithin, alfalfa, coenzyme Q10 with resveratrol, glucosamine, and an herbal immune supplement from the NHANES and NHANES-3 showed better conditions for C-reactive protein, HDL cholesterol, triglycerides, serum homocysteine, blood pressure, and incidence of diabetes. Diabetic patients who had been using multivitamins for 6 months had lower C-reactive protein concentrations and an inverse association with vitamins B6 and C. So let's go over that mix of stuff there again. So this is a multivitamin, multimineral, B complex, vitamin C, carotenoids, vitamin E, calcium, vitamin D, omega-3 fatty acids, flavonoids, lecithin, alfalfa, coenzyme Q10 with resveratrol, glucosamine, and an herbal immune supplement showed better conditions for C-reactive protein, HDL cholesterol, triglycerides, serum homocysteine, blood pressure, and the incidence of diabetes. Diabetic patients who had been using multivitamins for 6 months had lower C-reactive protein concentrations and an inverse association with vitamins B6 and C. And on the other hand, there are also studies that show opposing results. 1 year supplementation with multivitamins and minerals reduced the incidence of infections in type 2 diabetics, with subclinical micronutrient deficiencies. So it was concluded that the use of B complex antioxidants, so the use of vitamin B complex, the antioxidants, vitamin A, C, E, and carotenoids, calcium, vitamin D, vitamin K, magnesium, sodium, and potassium is not strongly associated with glucose metabolism, so as to recommend multivitamin or mineral supplementation above the normal recommendations for these nutrients. The current evidence does not support this. So conclusion, even though vitamins exert important effects on the risk of diabetes mellitus, as well as its progression and complications, so keep that in mind, the vitamins exert important effects on the risk of diabetes mellitus as well as its progression. They're claiming the evidence does not suggest individual or multivitamin supplementation. But do keep in mind, and maybe you should think for yourself, I'm not suggesting anything. Do your own research, but these vitamins exert an important effect on the risk of diabetes as well as its progression and complication. Okay, and of course they always say the best recommendation should be to consume adequate quantities of those foods that contain vitamins in sufficient amounts in order to guarantee an appropriate nutritional status. Now, to that I would say I would recommend people read the works, particularly Dead Doctors Don't Lie by Dr. Joel Wallach, and maybe look at my playlist on Dr. Joel Wallach, particularly the playlist dealing with the triage theory of aging and disease. And I'm going to move on. So the 90 essential nutrients that Joel Wallach talks a lot about, he talks a lot about the minerals in the 90 essentials. Okay, so what's the role of minerals and trace minerals in diabetes and insulin resistance? So let's see here. We're going to start here with where it goes. I think it's boron boron, an important but often underused trace micronutrient found in certain foods, plays a diverse and significantly important role in metabolism. The most relevant properties of boron in relation to human health include bone development and regeneration, wound healing, sex hormone production, vitamin D metabolism, and the absorption and use of calcium and magnesium. Studies have shown that dietary boron modulates plasma insulin concentrations. Okay, so let's see here. Calcium homeostasis plays a major role, as we just saw because of vitamin D, in insulin resistance and secretion. Calcium homeostasis is impaired in diabetes and contributes to defective cell regulation in red blood cells, cardiac muscles, platelets, and skeletal muscles. The impaired homeostasis is concerning as it could be a significant and contributory factor in the regulation of proper insulin secretion. Okay. Now, I want people to go back and read this on their own. The link will be in the description, of course. I'm rushing to finish this up quite a little bit earlier. So, cobalt, a number of studies have reported the typical serum values of cobalt are less than 0.5 micrograms per liter. I think that's micrograms per liter, showed that cobalt chloride decreased gluconeogenesis in diabetic rats. That means the release of it from the liver. Cobalt alone, or along with ascorbate, meaning vitamin C, reduces lipid peroxidation in visceral organs, meaning it helps reduce the oxidative damage in the visceral organs of diabetic rats. Chromium. Since the discovery of chromium as a trace metal in 1955, it has been found to effectively improve glucose tolerance by reducing insulin resistance. A China-based study showed that supplemented chromium improved blood glucose, insulin, cholesterol, HbA1c levels, hemoglobin A1c levels. Okay, type 2 diabetic patients in a dose-dependent manner. Proper chromium nutrition improves blood lipid profile and insulin action. Most diets cannot fulfill this suggested intake of 50 milligrams of chromium. Inadequate chromium leads to signs and symptoms similar to those of diabetes and cardiovascular disease. Chromium improves the glucose and insulin levels in subjects with hypoglycemia, as well as hyperglycemia, diabetes, and hyperlipidemia, meaning high blood fats, with no detectable effects on control subjects. Chromium also improves insulin binding receptor number and insulin receptor enzymes by increasing insulin sensitivity, beta cell sensitivity, and insulin internalization. Iodine deficiency leads to decreased thyroid hormone synthesis, which in turn leads to increased thyroid-stimulating hormone secretion and increased thyroid gland growth. A recent study showed that excess iodine diminished cell viability and compromised the function of insulin secretion. So you don't want too little and you don't want too much iodine, okay? Thyroid function is essential for regulating energy metabolism, and abnormal thyroid function may have substantial effects on blood glucose control in diabetes. Patients with diabetes mellitus are at an increased risk of thyroid disease. A study was conducted to assess the clinical implications of iodine status and Okay. Iron affects glucose metabolism. The bidirectional association between glucose homeostasis and iron metabolism is being increasingly acknowledged. Impaired iron uptake could be a contributing factor that affects glucose metabolism. Serum ferritin, meaning the iron in your blood concentration in type 2 diabetic patients, may affect insulin sensitivity, vascular resistance, viscosity, and oxidative damage. Both serum ferritin levels and BMI may act as independent predictors in glucose tolerance tests. Iron plays a major role in the adscription of type 2 diabetes, and not many markers of iron metabolism are known except for ferritin. Magnesium is a cofactor required for the movement of glucose into the cell and for carbohydrate metabolism. It is involved in cellular activity of insulin. Low magnesium intake is a risk factor for diabetes. Deficiency in magnesium inhibits cellular defenses against oxidative damage, which in turn results in a decreased resilience to oxidative stress caused by diabetes, thereby expediting the progression to diabetes-related complications. Therefore, hypomagnesemia, meaning low magnesium, may exacerbate type 2 diabetes. Selenium. Dietary selenium is a micronutrient that is essential for the synthesis of selenoproteins to carry out biological functions. Selenoprotein is recognized for its antioxidant and cytoprotective properties, and selenium supplementation is considered to be preventative due to its counteractive oxidative properties for the onset of metabolic diseases such as type 2 diabetes. In one cross-sectional analysis on U.S. adult serum selenium was measured by atomic absorption spectrometry in the diabetic population with a fasting plasma glucose level of 126 milligrams per deciliter. Diabetics with insulin treatment and a control group, after adjusting for age, sex, race, and BMI. The mean difference in serum selenium between diabetics and controls was 2.1 nanograms per milliliter. The study concluded that a high serum selenium is positively correlated with the prevalence of diabetes. However, no recommendation was provided about selenium supplementation or restriction for diabetics. Zinc is an essential micronutrient for metabolism that regulates more than 100 enzymes for protein folding, gene expression, as well as in the production of neutralization of basically your internal oxidative stress management. It plays an important role in cell signaling and cellular processes such as cell division and apoptosis, and disturbances in zinc homeostasis are associated with diabetes and insulin resistance. Zinc reduces cytokine production, and its deficiency may cause impairment of immunological functions. Zinc partially functions as an antioxidant, and zinc supplementation results in reduction of oxidative damage. So that means radical oxygen. So it reduces the creation of radical oxygen species, meaning free radicals, which is beneficial in aging and diabetes. Zinc deficiency augments the cytokine-induced damage in the autoimmune attack, resulting in the destruction of the islet cells. So the way that type 2 diabetes becomes hardcore diabetes is when the islet cells are destroyed by the immune system. Zinc helps to stop that. It might contribute toward diabetes. It might contribute to diabetes through genetic polymorphisms in the zinc transporter. Diabetes, insulin, and zinc have complex correlation. Diabetes affects zinc homeostasis, and it is also responsible for increased urinary loss and decreases in total body zinc. In 2003, a study compared zinc levels of Another study was conducted. Conclusion. Diabetes mellitus can alter the concentrations of trace elements and may further lead to changes in the nutritional status of an individual, although some micronutrients are known to be involved in the pathogenesis and progression of diabetes mellitus. Others may only be a consequence of depleted or altered carbohydrate intolerance and insulin resistance. The studies often report contradictory results. The serum or tissue contents of certain elements, blah, 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 such as copper, manganese, iron, and selenium may be higher in diabetic patients than in non-diabetic controls. Although the majority of diabetic patients do not have micronutrient deficiencies, zinc, chromium, and magnesium deficiencies have been identified in a subgroup of patients. More cohort, author contributions. And that's all for this video, and that's all.